Crisis Intervention Model by Jones HMMBADMS. There are many crisis intervention models, one of them being the ACT model of crisis counseling. ACT stands for Assessment, Crisis Intervention, and Trauma Treatment, and is a three-stage model emphasizing 1. Assessment of the presenting problem. 2. Connecting patients to support systems. 3. Helping those in crisis work through the distress and emotional pain. This three-stage intervention model integrates assessment and triage protocols with Robert's seven-stage crisis intervention model, RSSCIM, and is useful with persons calling or walking into an outpatient psychiatric clinic, psychiatric screening center, community mental health center, counseling center, or crisis intervention setting. The RSSCIM model identifies 7 critical stages a clinician goes through to help the individual reach stabilization, resolution, and mastery. The stages are sequential, but may overlap in the process. 1. Assessment. 2. Rapidly establish rapport. 3. Identify major problems. 4. Explore feelings and emotions. 5. Generate and explore alternatives. 6. Develop and formulate an action plan. 7. Plan follow-up. Stage 1. Assessment. The first step in the assessment of an individual experiencing a mental health crisis is to begin a fast but thorough biopsychosocial assessment, which includes inquiring about the major physical, psychological, and social issues of the person. This assessment should provide a brief medical history, medications being taken, current and past history of alcohol or drug use, environmental resources and supports available to the person, mental health problems and symptoms, as well as cultural considerations. Assessment should inquire about the support system and resources available to the person in crisis. Family and friends, social clubs, church groups, and networks of professional associates are all sources of support. When these resources are not available, caregivers act as a temporary support system for the patient. Some questions a clinician might ask about a support system are: with whom do you live? When you feel lonely and overwhelmed by life, whom do you talk to? Is there someone in your life whom you trust? In the past, during difficult times, whom did you want to help you? Where do you go to school, to worship, to have fun? Assessment of the level of anxiety the person is experiencing is conducted as well as the person's usual coping methods. Some people drink, some eat, some sleep, and some gamble. Others engage in physical activity, work harder, pick fights, or talk to friends. Some questions clinicians may ask about coping methods are: what do you do to make yourself feel better? Did you try doing that this time? If you did, what was different this time? Assessment of the person's strengths and needs also begins in this stage and continues throughout the crisis intervention. It is also important to determine whether the patient is unable to take care of personal needs such as eating, sleeping, and tending to personal hygiene and safety. Assessment of lethality is conducted to determine whether the person is suicidal or homicidal by asking: have you thought of killing yourself or someone else? How would you go about doing this? If there is any concern about suicidality, it is essential to find out what the person's thoughts are, if there is intent, and the strength of the intent, whether there is a plan and the lethality of the plan, any past history of suicide attempts, and other specific risk factors for suicide such as substance abuse, social isolation, or recent losses. In cases of imminent danger, emergency medical or police intervention is often necessary. See also assessing for risk of harm to self or others below. Stage 2. Rapidly establish rapport. Stage 1 and Stage 2 most often occur simultaneously. Establishing rapport and a collaborative therapeutic relationship begins with the initial contact between the crisis clinician and the person. The main task for the clinician at this point is to establish rapport by conveying genuine respect for and acceptance of the person's feeling and circumstances. The person may need reassurance that they can be helped and that this is the appropriate place to receive such help. The clinician demonstrates an understanding of the person's situation and feelings by showing patience and empathy, engaging in active listening, and concentrating on what the person is communicating verbally and non-verbally. It is also important to reinforce any evidence of the person's resiliency. Other ways in which rapport can be made is through eye contact, being non-judgmental, mirroring physical posture and movement to indicate listening intently, and the cautious use of touch to convey understanding. Stage 3. Identify major problems. This stage involves identifying the major problems the person is having, including the chain of events leading up to the crisis and the last straw that brought things to a head. The clinician encourages the person to examine when and how the crisis occurred, the contributing circumstances, and how the person attempted to deal with it. Questions clinicians might ask about a precipitating event are: what happened to make you so upset? How are you feeling right now? How does this event affect your life? How will this event affect your future? What needs to be done to fix the problem? Exploration of other problems the patient is concerned about is also accomplished during this stage. It can be useful to prioritize the problems in terms of which problems the person wants to work on first, recognizing that the focus of crisis intervention is the current problem rather than issues from the past. Stage 4. Explore feelings and emotions. It is extremely important to allow the person to vent feelings and emotions and to validate them by accepting them and recognizing them as understandable. This is best accomplished by using active listening skills, such as paraphrasing, reflective listening, and probing questions. With caution, the clinician may also challenge maladaptive thinking and behavior. Challenging responses can include giving the person information, reframing and interpreting thoughts and behaviors, and playing devil's advocate. How many times in the past have you had this kind of thought? Have you ever been wrong? What could you do to determine if this thought is true? Even if that's true, tell me if you can think of more positive behaviors you might engage in. When used appropriately, these challenging responses help the person take a second look at thoughts and behaviors and to consider other options. Stage 5. Generate and explore alternatives. This process may be the most difficult to accomplish in crisis intervention. People in crisis often lack the ability to see the big picture and hold on to familiar ways of coping, even when they are not working. The clinician draws conclusions about the patient's strengths and needs related to the current crisis and evaluates the potential for recovery. The person's strengths are tapped to improve self-esteem, which also provides the energy and skills for problem solving. During this stage of intervention, the clinician and the individual collaborate and negotiate to come up with options that will improve the current situation. It is important that such collaboration occur in order to ensure that the options selected are owned by the person. Brainstorming about possibilities or asking about what has been helpful in the past can elicit the person's input. Stage 6. Develop and formulate an action plan. At this point, there is a shift from crisis to resolution. The person and the clinician begin to take the steps negotiated in Stage 5, and the person begins to make meaning of the crisis event by exploring why it happened. It is important for the person to obtain a realistic picture and understanding of what happened and what led to the crisis. It is also important for the person to understand the specific meaning of the event and how it conflicts with expectations, life goals, and belief system. Working through the meaning of an event is important in order to gain mastery over the situation and for being able to cope with similar situations in the future. During this stage, the person begins to restructure, rebuild, or replace irrational beliefs and erroneous thinking with rational beliefs and new thinking. Action plans may also involve options such as entering a 12-step treatment program, joining a support group, or entering a women's shelter. These are often critical options for restoration of the person's equilibrium and psychological balance. Stage 7. Plan follow-up. A plan for follow-up with the person after initial intervention should be done to make certain the crisis is being resolved and to evaluate the post-crisis status of the person. Such an evaluation may include current functioning and assessment of progress as well as satisfaction with treatment. It is recommended for those individuals who are grieving that a follow-up session be scheduled around the 1-month and 1-year anniversary of a death. This is also recommended for individuals who are victims of violent crimes. Black and Flynn, 2021, Yeager and Roberts, 2015. Assessing for risk of harm to self or others. Individuals experiencing a mental health crisis should always be assessed for the risk of harm to self or others. The routine practice of undressing all patients and placing them in a gown serves as a non-confrontational way to search for weapons. The patient interview setting should be private but not isolated. The patient and clinician may be seated roughly equidistant from the door, or the clinician may sit between the patient and the door. The patient, however, should not sit between the clinician and the door, Moore and Pfaff, 2020. Assessing risk for suicide. The purpose of a suicide risk assessment is to determine a patient's risk and protective factors with a focus on identification of targets for intervention. There are a number of standardized scales available to evaluate risk of suicide, but none of them is associated with a high predictive value, Schreiber and Culpeper, 2019. A suicide risk assessment includes performing a clinical evaluation, identifying risk-enhancing factors, identifying risk reduction factors, employing clinical judgment. Different kinds of organizations and settings may use different screening tools. The following table lists examples of validated, evidence-based screening tools.